Welcome to the series where I'll be discussing the 2026 Consensus Statement on the Algorithm for Management of Adults with Type 2 Diabetes by ACE. This is Endo in a Bite, where I break down endocrine concepts or lengthy guidelines into focused, high-yield pieces you can actually remember. For the full board-centric framework, I've built it all out in Easy Endo Prep, designed to keep you efficient, current, exam-ready, and sharp in clinic. Visit www.ezendoprep.com to enroll in the full course or start your free trial. Today's focus is on reviewing the hypertension algorithm for reducing cardiovascular risk. Hypertension is extremely common in adults with type 2 diabetes, and it is not a minor side issue. It directly increases the risk of both macrovascular complications and microvascular complications. And even when patients are still in the pre-diabetic range, the combination of prediabetes and hypertension raises cardiovascular event risk. The UK prospective diabetes study showed that better blood pressure control reduced diabetes-related death, reduced microvascular complications, and reduced macrovascular complications. Later clinical trials confirmed the same general message. More intensive blood pressure control can improve cardiovascular risk outcomes in patients with type 2 diabetes. But before we treat, we should think. Type 2 diabetes and hypertension often travel together, but secondary causes of hypertension should still be considered. One of the most important conditions is primary hyperaldosteronism. It is often missed, treatable, and commonly seen in adults with type 2 diabetes. Some studies estimate it in about 10 to 20% of adults with type 2 diabetes. Recent guidance gives a conditional recommendation to screen adults with hypertension using plasma aldosterone concentration together with plasma renin activity or direct renin concentration. Interpretation can be tricky, especially when the patient is already taking antihypertensive medications that interfere with testing. Now let's talk about blood pressure goals. ACE has historically recommended a blood pressure goal for most adults with type 2 diabetes of less than 130 systolic and less than 80 diastolic millimeters of mercury. A lower target may be considered in patients with microalbuminuria, macroalbuminuria, moderate to high cardiovascular risk, established cardiovascular disease, peripheral vascular disease, or retinopathy. But not every patient tolerates aggressive lowering. Some patients may need a higher goal because of autonomic neuropathy, orthostatic hypotension, acute coronary syndrome, frailty, or medication intolerance. In clinic, use calibrated equipment, trained staff, the correct cuff size, and proper positioning. The patient should be seated in a chair, feet flat on the floor, with the arm supported at heart level. Ideally, take serial measurements and average them. 24-hour ambulatory blood pressure monitoring correlates better with cardiovascular risk than single office readings. It can detect masked hypertension where the clinic blood pressure looks normal but the outside blood pressure is high. It can also detect loss of the normal nighttime dip in blood pressure. Both findings are common in type 2 diabetes, and both are associated with higher cardiovascular risk, end organ damage, and mortality. Home blood pressure monitoring can also improve medication adherence and help patients reach their blood pressure goals. Management starts with lifestyle intervention. A 5% weight loss can lower blood pressure, and the largest benefit is often seen with 10% to more than 15% weight loss. Physical activity several times per week is important because both systolic and diastolic pressures can improve. This includes endurance exercise, aerobic exercise, and dynamic resistance training, such as free weights, resistance bands, exercise machines, or body weight resistance. Nutrition counseling is also essential. Limit dietary sodium. The DASH diet is a classic example, and it has been shown to improve 10-year cardiovascular risk by about 10%. The Mediterranean diet also lowers blood pressure. The PREDIMED study included patients with type 2 diabetes, and it showed improved primary prevention of ASCVD risk, with approximate 30% decrease in acute myocardial infarction, stroke, and cardiovascular death over 5 years. When medication is needed, start with an ACE inhibitor or an ARB. ACE and ARB therapy are considered first line for hypertension in adults with type 2 diabetes, especially when there is microalbuminuria. Both classes appear similarly effective, but do not combine ACE and ARB together. There is no added benefit, and there may be harm. Also, the direct renin inhibitor aliskiren should not be combined with either one of them. In the ALTITUDE trial, patients with type 2 diabetes and chronic kidney disease or cardiovascular disease who were already taking a RAS blocker had important safety concerns when aliskiren was added. These included hyperkalemia and hypotension without meaningful kidney or cardiovascular benefit. RAS blockers should be titrated regularly, at minimum every 2 to 3 months until the blood pressure goal is reached. If an ACE inhibitor causes cough, switch to an angiotensin receptor blocker. Thiazide diuretics and dihydropyridine calcium channel blockers are also effective initial therapies, especially when diabetic kidney disease or microalbuminuria is absent. If the starting blood pressure is above 150/100, consider starting dual therapy from the outset. If the goal is not reached with optimized initial meds, add-on therapy is needed. Thiazide diuretics are effective second-line choices. Examples include hydrochlorothiazide, chlorthalidone, and indapamide. Many fixed-dose combination pills exist, and they may improve adherence. Dihydropyridine calcium channel blockers, such as amlodipine or nifedipine, are also useful add-on options. Many adults with hypertension require multiple medications to reach goal. For resistant hypertension, think carefully. Resistant hypertension generally means blood pressure above 140/90, despite 3 medications, including a maximum dose diuretic. In this setting, mineralocorticoid receptor antagonist therapy should be considered. Examples include spironolactone and finerenone. Sodium retention is a major driver of resistant hypertension. When adding a mineralocorticoid receptor antagonist to a RAS blocker, monitor potassium and kidney function. Recheck about 1 week after initiation, again after dose changes, and then routinely. Check more often in patients at higher risk for hyperkalemia. Finerenone is another important option. Finerenone is a nonsteroidal mineralocorticoid receptor antagonist with data supporting benefit in adults with type 2 diabetes and chronic kidney disease. Benefits include slowing chronic kidney disease progression, lowering heart failure risk, lowering cardiovascular events, and lowering related mortality. It is also useful in macroalbuminuria and in more advanced chronic kidney disease when GFR is at least 25 milliliters per minute per 1.73 meters squared. Finerenone can modestly lower systolic blood pressure, but many of its benefits appear independent of baseline blood pressure. Regulatory approval includes reduction in GFR decline, end-stage kidney disease, cardiovascular death, non-fatal myocardial infarction, and hospitalization for heart failure. Other add-on agents include alpha and beta blockers. However, there is a weight gain concern with beta blockers, possibly due to decreased energy expenditure, and this is more common with older agents like atenolol and metoprolol. More weight-sparing choices include alpha-beta blockers like carvedilol, labetalol, and dilevolol, as well as beta-1 selective agents like nebivolol and betaxolol. Additional resistant hypertension options include central alpha-2 agonists, including clonidine, peripheral alpha-1 blockers like doxazosin, prazosin, and trazzosin, and direct vasodilators like hydralazine. Keep in mind, hydralazine requires multiple daily dosing. I also wanted to emphasize that diabetic meds can also lower blood pressure. Mild systolic reduction can occur with GLP-1 receptor agonists, approximately 1 to 2 millimeters mercury, and SGLT2 inhibitors, approximately 3 to 5 millimeters lowering. Let's end with numbers to remember. Blood pressure goal, less than 130/80 for most patients with type 2 diabetes. Start an ACE or an ARB when urine albumin to creatinine ratio is over 30 milligram per gram or higher. Start dual therapy when blood pressure is above 150/100. Resistant hypertension is more than 140/90 on 3 meds, including a diuretic. Spironolactone dosing in resistant cases, 25 to 50 milligrams. Weight loss, 5% lowers blood pressure, 10 to 15% gives greater reduction. SGLT2 inhibitor effect, about 3 to 5 millimeter reduction. GLP effect, about 1 to 2 millimeter mercury reduction. Again, target 130/80. Start kidney protective therapy at 30 milligram per gram. Escalate at 150/100. And think mineralocorticoid receptor blockade when 3 medications are not enough. This was another bite-sized episode of Endo in a Bite. If a detail went by too quickly, don't worry. I've prepared the notes for you. Visit www.easyendoprep.com to sign up for the weekly newsletter and have all the key pearls delivered straight to your inbox. You can also purchase the full board review course there for deeper learning and ABIM exam preparation. Remember, stay consistent, and together we'll work through the ACE consensus statement on the algorithm for the management of dyslipidemia, one bite at a time.